Okay, let's unpack this. When we talk about something like chest pain, something that seems maybe simple on the surface, what we're really diving into is this incredibly intricate uh, balancing acts within your body.
That's right.
Today, we're taking a truly deep dive into vasodilators and the treatment of angina pectoris and coronary syndromes. We're drawing from some fantastic sources, especially KATZUNG's basic and clinical pharmacology, to really help you master this information,
Yeah,
like the elite professionals do.
indeed. And our mission really is to give you a shortcut, to get you truly well informed, exploring not just what these vital medications do, but precisely how they do it and, why they matter so much.
Yeah, the underlying principles.
Exactly. The
Sure.
principles that guide those real-world medical decisions.
We'll unravel the different kinds of angina, peek into the heart's delicate oxygen demands,
Yeah.
its budget, really, and then dissect the remarkable ways different drugs step in. We even got a case study, a 67-year-old woman whose situation will kind of anchor our discussion, bring these complex ideas to life, help connect the dots.
It makes it much more real.
Exactly. So get ready for some surprising facts, maybe some aha moments today.
Let's do it.
First, let's just establish our baseline. What exactly is angina, and why is it such a significant concern for so many people?
Okay, so angina pectoris. At its core, yes, it's chest pain, but it's a very specific kind of chest pain. It's caused by this buildup of metabolic waste products inside the heart muscle itself.
Okay.
And that happens when there's an imbalance. Basically, the heart muscle needs more oxygen than its own blood supply the coronary vessels can actually deliver.
The supply and demand problem.
Exactly. A fundamental supply and demand problem. And it's a critical issue,
Yeah.
Ischemic heart disease, that's the big umbrella term for when the heart isn't getting enough blood, is one of the most common cardiovascular diseases, certainly in developed countries.
So it's this basic mismatch. But I guess not all angina is created equal. Are there different types, different flavors of this oxygen problem?
That's a crucial distinction, absolutely. We actually categorize angina into several types, and understanding these differences is really key if you want to treat it effectively.
Okay.
The most common type is effort angina, sometimes called classic angina. Its main cause is usually a blockage, typically from plaque buildup, that's atherosclerosis, or coronary artery disease, CAD in the large coronary vessels.
The main pipes.
The main pipes, yeah. So the imbalance, the pain, it shows up when the heart's oxygen demand increases, especially during physical activity like exercise. The narrowed arteries just can't ramp up the blood flow enough.
Makes sense.
Diagnosis there is often based on the patient's history, maybe stress testing, sometimes coronary angiography, to actually look inside those arteries.
Okay, what else?
Then there's something called coronary microvascular dysfunction. You might hear it called coronary syndrome X. Now here, patients get those typical angina symptoms, the chest pain. But when doctors look at their large coronary arteries, they seem normal.
So the main pipes are clear.
Right. The problem isn't in the big highways, it's in the tiny, intricate network of smaller vessels, the microvessels. This is often linked to those small vessels not being able to widen properly, what we call impaired vasodilation or endothelial dysfunction, where the lining of the blood vessels isn't working right.
Fascinating. So it's subtler.
Much subtler. And then we have vasospastic angina, also known as variant angina or Prinz metal angina. This one's a bit different again. It involves a sudden temporary spasm. Parts of the coronary vessels just clamp down.
A spasm. Like a muscramp, but in the artery.
Sort of, yeah. It often happens in areas where there might already be some plaque buildup. But the primary issue is the spasm itself. So in this case, it's the delivery of oxygen that suddenly drops, rather than the heart needing more. Diagnosis, again, relies on history, sometimes confirmed by tests that can actually provoke a temporary spasm under controlled conditions.
Wow. So similar pain, but really different root causes. Is it possible for this oxygen shortage to happen without any pain at all?
Absolutely. That's another important piece. Some people experience what we call silent ischemia or ambulatory ischemia. Their heart muscle isn't getting enough oxygen, but they feel nothing, no pain.
That sounds dangerous.
It can be because it goes undetected. It really highlights why diagnosis isn't always straightforward. And then there's the most urgent type, unstable angina. This falls under the serious umbrella of acute coronary syndrome, or ACS.
Okay, this is the emergency one.
This is the emergency. It's characterized by angina that happens at rest or a sudden worsening, more severe, more frequent, lasting longer in someone who previously had stable angina, or just brand new onset angina. It's often caused by increased resistance in those big coronary arteries or tiny unstable blood clots, platelet clots forming on a damaged bit of plaque,
Old clots breaking off.
or forming right there, often partially blocking the vessel. Inflammation can play a role too. We really have to emphasize this. Unstable angina is a true medical emergency because there's a high risk it could progress to a full heart attack or even death.
Which brings us right back to our patient, the 67-year-old woman, her history. Exercise-induced angina, but now it's happening at rest, and the nitroglycerin isn't helping. Plus her risk factors, smoking, high cholesterol, hypertension.
Classic risk factors.
Yeah, it really paints a clear picture, doesn't it?
Yeah.
Her symptoms are pointing strongly towards acute coronary syndrome,
Yeah.
making her situation an emergency.
Absolutely.
So understanding these different types, it's not just academic.
Yeah.
It's absolutely critical for making those rapid, life-saving treatment decisions.
Couldn't agree more. And to really understand how we treat angina, we first have to master that delicate balance, the heart's demand for oxygen versus its supply.
Right, the oxygen budget.
Exactly.
Yeah.
Let's dig into the mechanics of what the heart needs and how it gets it, because honestly, every treatment decision flows from understanding this.
Okay.
So the major things determining how much oxygen the heart muscle needs. First, there's wall stress. Think of it as how hard the heart has to physically work to pump blood out.
The tension on the muscle.
Precisely. It's influenced by the pressure inside the ventricle, the size or volume of the ventricle, and how thick the heart wall is. Then there's heart rate. Pretty straightforward. Faster beat means more contractions, more oxygen needed.
Yep.
And finally, contractility. That's the inherent force, the strength of each muscle squeeze.
How hard it pumps each time.
Exactly. Now, all these factors, wall stress, rate, contractility, they all shoot up during physical exercise. Or when your body's under stress, sympathetic discharge. And that's often what triggers angina in people with blockages.
Right, the demand outstrips the supply.
Precisely. So a key strategy for many drugs is to reduce that oxygen demand. They do this by decreasing the heart size, slowing the rate, or reducing the force of contraction. Think about vasodilators, beta blockers, calcium channel blockers. That's a big part of how they help.
And you mentioned a metabolic angle too, something about fuel.
Yeah, that's another layer. The heart normally prefers to burn fatty acids for energy. It's efficient, but it requires more oxygen per unit of energy produced compared to burning carbohydrates like glucose.
Interesting.
So this leads to this concept of a metabolic shift. There are drugs or potential drugs that encourage the heart to use more glucose, and by doing that, they could, at least theoretically, reduce oxygen demand without directly changing how hard the heart is pumping.
A different way to save oxygen.
Exactly. Now let's flip to the other side. Coronary blood flow and myocardial oxygen supply. In a healthy heart, when demand goes up, the coronary arteries just widen. They deliver more blood. Simple.
But what governs that flow?
Crucially, blood flow to the heart muscle itself drops almost to zero during systole. That's when the heart is contracting, squeezing blood out.
Right, it squeezes its own supply lines shut.
Pretty much. So most coronary flow happens during diastole when the heart muscle is relaxing and refilling. This means coronary flow is directly tied to the pressure in your aorta during diastole and also the duration of diastole. How long does it have to relax and fill?
So a really fast heart rate is bad for supply too.
Absolutely. Tachycardia significantly shortens that diastolic time, limiting the time for the heart muscle to get its own blood supply. Coronary blood flow is also inversely proportional to coronary vascular resistance, meaning the tighter, the more constricted those vessels are, the less blood gets through. That resistance is influenced by lots of things, local metabolic products, nerve signals, and importantly, it can be modified by drugs. We also have to remember damage to the inner lining of the vessels, the endothelium, that can really impair their ability to dilate properly.
Okay, and what about vascular tone elsewhere in the body? How does that fit in?
Right, vascular tone plays a huge role. The tone of your peripheral arterioles, those tiny arteries all over your body, directly controls your overall peripheral vascular resistance. And that, in turn, determines your arterial blood pressure.
Which affects the heart's workload.
Directly. That blood pressure is the resistance the left ventricle has to pump against its afterload, which impacts systolic wall stress. Then there's venous tone. That determines how much blood the veins can hold their capacitance and controls how much blood comes back to the heart, the preload.
Which affects the right side of the heart's work.
Exactly, the right ventricular diastolic wall stress.
Wow. What's truly fascinating here is just how incredibly interconnected all these factors are. It's not just one thing, is it? It's like this whole cascade of effects, a domino chain in your body.
It really is.
And understanding this complex interplay, demand, supply, vascular tone that's the bedrock, that's how you appreciate how these therapies actually work at such a fundamental level. It's like learning the language the heart speaks when it's in trouble.
Beautifully put. And now let's get into those elegant molecular mechanisms. How these drugs actually relax vascular smooth muscle. This is where pharmacology gets really precise. They're basically hacking the body's own relaxation pathways.
Hacking the system. I like it.
So fundamentally, smooth muscle contraction gets triggered by calcium coming into the cell. More calcium, more contraction. But drugs can intervene in 4 main ways to cause vasodilation, making the vessels widen.
Okay, mechanism 1.
First, by increasing CGMP. Cyclic guanosine monophosphate. Think of CGMP as a key relax signal inside that muscle cell.
A specific messenger.
Exactly. It essentially tells the little protein gears responsible for contraction, the myosin light chains, to unhook from actin. It facilitates their dephosphorylation. No interaction, no contraction, relaxation.
Got it.
Now, nitric oxide, NO, is a potent natural activator of the enzyme that makes CGMP soluble guanylyl cyclase. So drugs that act as NO donors are key here. Things like nitroprusside, used in hypertensive emergencies, and the organic nitrates we use for angina, like nitroglycerin.
So they boost that natural NO signal.
They do. And it's important to remember, in conditions like atherosclerosis, the body's own ability to make NO from the vessel lining, the endothelium, can be reduced. That makes the vessels more reliant on these outside sources of NO from drugs.
Right. The natural pathway is compromised, so the drugs step in. What's the second mechanism?
Second is directly decreasing intracellular calcium. Calcium channel blockers, the name says it all, right? They literally block the channels that let calcium into the cell.
Less calcium, less contraction fuel.
Exactly. Less calcium means less activation of the enzymes, like myosin light chain kinase, that kick off contraction. And it's not just smooth muscle. These drugs also reduce calcium entry into heart muscle cells. That helps reduce heart rate, reduces the force of contraction, and ultimately lowers the heart's oxygen demand.
2 birds with 1 stone, kind of.
In a way, yes. Okay, third mechanism. Drugs can cause vasodilation by stabilizing the vascular smooth muscle cell membrane, basically preventing it from getting electrically excited or depolarizing. They do this by increasing its permeability to potassium ions,
Letting potassium out.
letting potassium flow more easily, which keeps the cell's electrical potential closer to its resting, relaxed state, makes it harder to excite. Interestingly, CGMP itself might play a role here too, potentially opening certain potassium channels. We see this mechanism with drugs like minoxidil sulfate, known as potassium channel openers, and nicorandil, used elsewhere, also works partly this way.
Okay, and the 4th pathway.
Fourth is increasing CAMP in vascular smooth muscle cells. Cyclic adenosine monophosphate. An increase in CAMP essentially hits the off switch for that myosin light chain kinase enzyme we mentioned. It increases its rate of inactivation.
So another way to stop the contraction machinery.
Right. This is how beta-2 agonists cause vasodilation and drugs like phenyldopaum. And this is crucial, these are generally not used in angina. Why? Because they can also cause excessive stimulation of the heart muscle itself, which would increase oxygen demand. Counterproductive.
Oh,
Thank
okay.
you.
That makes sense. So here's where it gets really interesting, connecting back to that idea of mastery.
Yeah.
It's not just about vaguely opening up blood vessels. It's about these specific, intricate cellular pathways that the drugs hijack or amplify.
Precisely.
Nitric oxide, calcium, potassium channels, CAMP. These are the fundamental levers the body uses for relaxation. And these drugs are designed to tap into them with, well, remarkable precision.
That's the elegance of it.
Let's dive into the workhorses then. The organic nitrates. Nitroglycerin leading the charge. What's the story here? These have been around forever, haven't they?
They really have. Chemically, they're quite simple organic esters of nitric and nitrous acid. Nitroglycerin is the classic prototype used for cardiovascular issues for, believe it or not, over 160 years.
Wow. And isn't that related to dynamite?
It is. Same core molecule. But the medicinal forms are processed, so they're completely non-explosive, don't worry. A practical point, though. Those little sublingual tablets, they can actually lose their punch over time. The drug can volatilize or even stick to plastic containers, so they need to be kept in tightly closed glass containers.
Good tip. Light sensitive.
Nope, not sensitive to light. Now, all the nitrates that work therapeutically share the same basic mechanism and similar side effects. What really makes them different is how the body handles them, their pharmacokinetics. That's what governs which form we choose for a patient.
Okay, so how does the body handle them? And why does that dictate how we give them?
The big issue is the liver. Your liver has this really efficient enzyme system, organic nitrate reductase, that just chews them up and inactivates them. This leads to a huge first-pass effect.
Meaning if you swallow it, not much gets through.
Exactly. If you take a standard nitroglycerin pill orally, very little active drug actually makes it into your general circulation. The liver gets it first. And that's why sublingual administration under the tongue is the go-to for rapid relief.
Bypasses the liver.
Right. It gets absorbed directly into the bloodstream there. Works within minutes. But the downside is it doesn't last long, maybe 15 to 30 minutes.
So for longer effects.
For longer duration, we use specially formulated oral preparations that contain enough drug to kind of overwhelm that first pass effect. Or we use things like transdermal patches or buccal tablets that provide a slow, continuous release over hours.
What about that amyl nitrite stuff, the poppers? Is that used anymore?
Amyl nitrite. It's a highly volatile liquid, rapidly absorbed by inhalation, also bypassing the liver. But honestly, due to its really unpleasant smell and extremely short action, it's pretty much obsolete for angina treatment now.
Okay, so the original drugs are short-lived, but what about their breakdown products?
Good point. While the unchanged organic nitrate compounds have very short half-lives, just minutes, some of their metabolites, the partially denatrated forms, are actually still active vasodilators and hang around much longer, up to 3 hours.
So they contribute to the effect too.
They certainly can. For instance, one metabolite of isosorbide denatrate is active and available orally with 100% bioavailability. The body eventually gets rid of these drugs and their metabolites mainly through the kidneys.
Okay, so that's how they get in and out. How do they actually work in the smooth muscle, the pharmacodynamics?
Right. Nitroglycerin isn't actually active itself. It has to be bioactivated inside the body to release that crucial nitric oxide, NO. This needs enzymes. Specifically, mitochondrial aldehyde dehydrogenase isoform 2, ALDH2, seems key for nitroglycerin.
An enzyme unlocks the NO.
Pretty much. Once the free nitrate ion is released, it gets converted to NO, which then activates that enzyme's soluble guanylate cyclase. That boosts cGMP levels, and like we said, cGMP leads to smooth muscle relaxation. That's the main pathway.
And then there's a big one, tolerance. You can't just keep giving it, right? It stops working.
Exactly. Tolerance is a huge clinical consideration. With continuous exposure, the smooth muscle can develop complete tolerance. We call it tachyphylaxis. The drug just loses its effectiveness pretty quickly.
Why does that happen?
It's complex. It likely involves several things. The body might get less efficient at activating the drug, maybe depleting substances needed for activation, or even generating more damaging free radicals that interfere.
Is that why you need nitrate-free periods?
Precisely. That's why dosing schedules for long-acting nitrates always include a nitrate-free interval, usually overnight, to allow sensitivity to recover. There's a fascinating historical example called Monday disease.
Monday disease.
Yeah. Workers in dynamite factories exposed to volatile nitrates all week would get headaches and dizziness on Monday morning after the weekend off. By Tuesday or Wednesday, they'd develop tolerance, symptoms gone. Then, come the next Monday, symptoms back again.
Wow. A perfect example of tolerance developing and resetting.
It really is. Now, beyond the cellular level, let's look at the organ system effects. Nitroglycerin relaxes basically all types of smooth muscle, but its effects on vascular smooth muscle are the most important for angina. It relaxes everything from large arteries to large veins.
Veins more than arteries.
Yes, veins respond at the lowest concentrations, and this is key. Marked relaxation of veins increases their capacity to hold blood-venous pooling. This decreases the amount of blood returning to the heart, the preload.
Which takes the strain off the heart.
Exactly. Less preload reduces the heart's size, reduces the pressure inside, and significantly reduces the heart's oxygen demand. That's the primary benefit in effort angina. Now, this venous pooling can also cause that drop in blood pressure when standing up orthostatic hypotension, sometimes even fainting. And the headache. The classic throbbing headache comes from dilation of arteries in the head, particularly the meningeal arteries. The body also fights back against the low blood pressure with compensatory responses, faster heart rate, increased contractility, and those responses actually contribute to developing tolerance over time.
Does it actually increase blood flow to the heart in blocked arteries?
That's debatable. There's no strong evidence it increases total coronary flow in patients with significant fixed blockages. However, it might help redistribute the flow that is there, maybe shunting it from well-supplied areas to ischemic areas.
Okay. Any other effects?
Platelets?
Nitric oxide can decrease platelet aggregation, which might be theoretically helpful in acute coronary syndromes, but studies haven't shown a survival benefit for nitroglycerin itself in acute heart attacks.
And you mentioned something really surprising about cyanide. Ah, yes. This is fascinating. Nitrite ion toxicity and the antidote effect. In very large doses, the nitrite ion can react with hemoglobin in red blood cells, converting it to methemoglobin. Methemoglobin can't carry oxygen well, leading to hypoxia. That's the toxicity.
Okay.
But this toxic effect is cleverly turned into a cyanide poisoning antidote. If you give sodium nitrate intravenously soon after cyanide exposure, it rapidly creates methemoglobin. Methemoglobin has a super high affinity for cyanide, so the cyanide binds to the methemoglobin instead of poisoning vital cellular enzymes. It basically sacrifices some hemoglobin to trap the cyanide.
That's incredible, using the drug's toxicity therapeutically.
It really is. Then you use other agents to detoxify the trapped cyanide. A very unexpected twist for a simple heart medication.
So thinking back to our patient, what does this all mean? The seemingly simple nitroglycerin, it's actually this incredibly complex molecule, been around forever, relies on specific enzymes, messes with blood pressure, causes tolerance, and it's even a cyanide antidote. And that tolerance issue is exactly why just giving her more isn't the answer for her worsening pain. It really highlights the precision needed.
Absolutely. Which leads us nicely to our next major class. The calcium channel blockers, or CCBs.
Right. Another versatile group.
Incredibly versatile. They intervene, as the name suggests, at that fundamental level of calcium influx, which we know is crucial for muscle contraction, both smooth muscle and cardiac muscle.
And they target specific calcium channels.
Yes. While there are different types of calcium channels, the ones we're interested in for these drugs are mainly the L-type channels. They're the dominant type in heart and smooth muscle, and the target for the CCBs we use clinically.
Okay. What are they like chemically? How does the body handle them?
Well, verapamil was the first one, derived from a plant alkaloid. Then you have the big family of dihydropyridines. Nifedipine is the prototype there, but there are many others. They're generally taken orally, and like some nitrates, many have a significant first-pass effect in the liver.
So the liver takes a cut again.
It does. They also tend to bind strongly to proteins in the blood. Verapamil and another one, diltiazem, can also be given intravenously if you need rapid effects.
And how do they actually block those channels? The mechanism.
Okay, so the L-type calcium channels are voltage-gated. They open and close based on electrical signals. They have specific docking sites for these drugs. Dihydropyridines bind to one site, while verapamil and diltiazem bind to slightly different but related sites on the same channel subunit.
Different keys for slightly different locks on the same door.
Kind of, yeah. And when the drug binds, it reduces how often the channel opens when the cell gets that electrical signal. The result, a big drop in calcium flowing into the cell.
And that causes relaxation.
In smooth muscle, yes, it leads to long-lasting relaxation. In cardiac muscle, it reduces contractility, the force of the squeeze, and it also slows down the heart's pacemaker activity in the sinus node and electrical conduction through the AV node.
Does it affect other calcium channels? Nerves.
Generally, other calcium channel types are much less sensitive. So neurons, secretory glands, they're usually less affected at therapeutic doses.
Okay, so focusing on smooth muscle and the heart. What are the broader effects on organ systems?
Right. Organ system effects. Most types of smooth muscle get relaxed. Vascular, bronchial, GI tract, uterine. But vascular smooth muscle is the most sensitive. And within that, the arterioles, the small resistance arteries, are more sensitive than veins.
So less likely to cause that standing up dizziness than nitrates.
Generally, yes. Orthostatic hypotension isn't usually as common with CCBs. By relaxing those arterioles, they lower peripheral resistance, reduce blood pressure. That directly helps in effort angina by reducing the afterload, the work the heart has to do. And they're great for variant angina because they relax those coronary artery spasms.
Are they all the same in how much they affect blood vessels versus the heart?
No, that's a key difference, vascular selectivity. Dihydropyridines, like nifedipine or amlodipine, tend to have a much greater effect on vascular smooth muscle relative to their effect on the heart muscle itself, compared to, say, verapamil and diltiazem, which have more balanced effects or even more pronounced cardiac effects.
Okay. And the direct effects on the cardiac muscle?
As we said, the heart depends heavily on calcium influx, so all CCBs can slow the heart rate by acting on the SA node and slow conduction through the AV node. They also reduce contractility dose-dependently. Verapamil and diltiazem are particularly good at slowing down certain types of fast heart rhythms that depend on calcium influx. Dihydropyridines generally have less of that direct depressant effect on the heart's rhythm and contractility.
What of skeletal muscle, like your arms and legs?
Not depressed. Skeletal muscle works differently. It uses calcium stored inside the cell for contraction. It doesn't rely so much on calcium coming in from the outside.
Interesting difference. Any other notable effects? You mentioned brain issues earlier.
Yes, cerebral vasospasm. Certain CCBs, like nicardipine and verapamil, are used often infused directly into arteries to prevent or treat the dangerous blood vessel spasms that can happen after a subarachnoid hemorrhage, a type of stroke. There's some suggestion they might also help reduce brain damage after other types of stroke.
And other miscellaneous effects.
They generally don't interfere much with hormone release. Verapamil might inhibit insulin release at high doses. Some in vitro evidence suggests they might affect platelet aggregation or even slow atherosclerosis in animals, but the clinical role there isn't really established. One intriguing area is P-glycoprotein verapamil can block this pump that throws cancer drugs out of cells, potentially helping overcome drug resistance. And there's ongoing research into roles in osteoporosis, fertility, even parasitic diseases.
Wow, that's quite a range. What about the downsides, the toxicity?
Well, the main toxicities are really just extensions of their therapeutic effects. Too much calcium channel blockade can cause serious cardiac issues. Excessive slowing of the heart rate, bradycardia, heart block, problems with electrical conduction, worsening heart failure, even cardiac arrest in extreme cases, though these are rare when used properly.
But there was that issue with nifedipine.
Yes, a very important caution. The prompt-release, short-acting form of nifedipine was linked in some studies to an increased risk of heart attacks in hypertensive patients. Because of this, that specific formulation should absolutely be avoided. The slow-release and long-acting dihydropyridines are generally much safer and well-tolerated.
Good to know. Any interactions?
Patients already on beta blockers are more sensitive to the heart-depressing effects, so that combination needs care. Minor side effects include things like flushing, dizziness, nausea, constipation, especially common with verapamil, and sometimes ankle swelling, peripheral edema.
This really brings up that question again. Why are there so many different CCBs? And why is choosing the right one so critical?
Exactly. It's because of slight differences in vascular versus cardiac effects, their selectivity, their duration of action. They have huge implications for tailoring treatment to the specific patient and ensuring safety. It's not just a calcium channel blocker. The details really, really matter. That's where the mastery comes in.
Okay, so we've dissected the nitrates, the calcium channel blockers, and we've mentioned beta blockers. Let's bring it all together now. How do these different classes actually orchestrate a treatment plan for different types of angina? And thinking back to our patient.
Right. Let's connect the mechanisms to the clinical effects. For angina of effort, that classic exercise-induced pain, the main benefit of nitrates is reducing oxygen demand. They do that primarily by relaxing veins, decreasing preload, which reduces the heart size and wall tension, less work for the heart.
Takes the load off.
Exactly. They might also help dilate large coronary arteries and redistribute flow. Calcium channel blockers also reduce oxygen demand by decreasing the heart's contractility and the pressure it pumps against after load. Some, like verapamil and diltiazem, have some additional helpful antiadrenergic effects.
And the beta blockers, you said they were key here.
Yes, beta-blocking drugs are generally considered first-line prophylactic treatment for chronic effort angina. Now, most aren't vasodilators themselves.
Except maybe a couple.
Right, carvedilol and nebivolol have some vasodilating properties, but the main benefit of beta blockers is hemodynamic. They slow the heart rate, lower blood pressure, and decrease contractility, all of which dramatically cuts down the heart's oxygen needs, both at rest and during exercise. Plus, that slower heart rate increases diastolic time, potentially improving coronary perfusion. They improve symptoms and outcomes, also very valuable for silent ischemia.
Okay, what about the other types? Vasospastic angina?
For vasospastic angina, it's nitrates and calcium channel blockers that are the stars. They work by directly relaxing the smooth muscle in those spasming epicardial coronary arteries. They relieve the spasm and prevent future episodes. Importantly, beta blockers are not helpful here and might even make it worse.
Good distinction. And for the really serious stuff, unstable angina and acute coronary syndromes, like our patient.
Right. For her situation, ACS without clear signs of a major heart attack on the EKG initially, the goal is immediate treatment to restore coronary flow. The best option, if available quickly, is PCI, percutaneous coronary intervention, angioplasty and stenting.
Opening the artery mechanically.
Exactly. If PCI isn't readily available, then fibrinolytic clot-busting drugs like Alteplase might be considered. Because unstable angina often involves those platelet-rich clots, aggressive antiplatelet therapy is crucial, usually aspirin plus another agent like clopidogrel.
Stopping more clots from forming.
Yes, and if stenting is done, often more potent intravenous antiplatelet drugs, the glycoprotein Ibera inhibitors, are added during the procedure. Nitroglycerin, often IV initially, and beta blockers are also standard components of care. Calcium channel blockers might be used if the ischemia persists despite other treatments. And then long-term, you start therapies to manage the underlying disease. High-dose statins for cholesterol, ACE inhibitors.
So it's a very aggressive, multi-pronged attack for ACS. What about just maintaining someone with chronic stable angina, long-term?
For maintenance therapy of chronic stable angina, the mainstays are beta blockers, long-acting calcium channel blockers, or long-acting nitrates. The choice often depends on the individual patient. Do they also have high blood pressure? Maybe a beta blocker or a long-acting CCB is a good first choice. Normal blood pressure, perhaps long-acting nitrates?
Did you combine them?
Oh, absolutely. Combination therapy is often more effective. Combining drugs with different mechanisms can give better symptom control or allow you to use lower doses of each, minimizing side effects.
Like beta blockers and nitrates balancing each other out.
That's a classic combo. The nitrate counteracts potential increases in heart size from the beta blocker, and the beta blocker prevents the reflex increase in heart rate the nitrate might cause. Combining a beta blocker with a dihydropyridine calcium channel blocker, like amlodipine, is also very common and effective. Remember to use the long-acting CCBs here.
What if that's still not enough?
If someone has refractory stable angina, despite optimal doses of, say, 3 different types of antianginal drugs, then it's usually time to strongly consider coronary angiography to assess the blockages and look at revascularization options, either PCI, stenting, or CABG, bypass surgery.
And you mentioned some specific cautions when choosing or combining CCB.
Yes, definitely. For instance, if a patient has underlying heart conduction problems like AV block, a dihydropyridine like nifedipine or amlodipine is generally safer than verapamil or diltiazem. Combining verapamil or diltiazem with a beta blocker significantly increases the risk of severe bradycardia or heart block, so that needs extreme caution or avoidance.
What about heart failure?
Most CCBs can worsen heart failure because they reduce contractility. The notable exception is amlodipine, which studies have shown can be used safely in patients with heart failure due to systolic dysfunction, as long as it's not primarily ischemic.
And blood pressure considerations.
If someone already has borderline low blood pressure, the potent vasodilation from dihydropyridines might drop it too much. Verapamil or diltiazem might be better tolerated in that scenario. Conversely, if the patient also has certain atrial arrhythmias like atrial fibrillation, verapamil and diltiazem offer the added benefit of helping control the heart rate.
And just to hammer it home, the short-acting CCBs.
Prompt-release, short-acting CCBs are contraindicated in unstable angina and acute MI. Full stop. Increased risk.
Got it. This section really drives home the practical side, doesn't it?
Yeah.
It's not just about knowing the drugs, but how to tailor them, combine them, avoid pitfalls. It's a real balancing act based on the specific angina type and the whole patient picture. That's the clinical art and science.
Precisely. And what's really fascinating is how these same principles, nitric oxide, calcium signaling, extend beyond angina into treating other conditions, and how research keeps finding new targets. Take erectile dysfunction, for example.
Okay, how does that connect?
Well, achieving an erection requires relaxation of specific smooth muscle in the corpora cavernosa of the penis that allows blood to flow in. And guess what triggers that relaxation physiologically?
Let me guess. Nitric oxide.
Bingo! Nitric oxide released from nerves activates guanylyl cyclase, increases cGMP, and leads to smooth muscle relaxation. Same pathway we saw in blood vessels.
Ah, so drugs like sildenafil, Viagra, they tap into that.
Exactly. Sildenafil, tadalafil, vardenafil, they're all PDE5 inhibitors. They work by stopping the breakdown of cGMP by that specific enzyme, phosphodiesterase type 5. More cGMP means more relaxation, better blood flow.
Makes sense. But they need the initial signal, right?
Correct. They don't cause the erection. They enhance the body's natural response to stimulation. They won't work without nerve signals or libido. Now, here's the critical interaction we absolutely have to highlight again.
Nitrates.
Yes. Because both nitrates and PDE5 inhibitors work by increasing cGMP, nitrates by boosting production, PDE5 inhibitors by blocking breakdown, taking them together can cause a massive drop in blood pressure. Severe hypotension, even heart attacks have occurred.
So never take them together.
Absolutely not. The standard recommendation is to wait at least 6 hours, sometimes longer depending on the specific PDE5 inhibitor, between taking a nitrate and taking one of these drugs. It's a potentially lethal combination.
Wow. Good to know.
Yeah.
Any other uses for those PDE5 drugs?
Yes. They're also approved and show clear benefit for pulmonary arterial hypertension, high blood pressure in the lungs, also for BPH. And research suggests potential benefits elsewhere, too. For ED patients who don't respond to PDE5 inhibitors, other options exist, like alprostadil, a prostaglandin given by injection or suppository.
So a powerful lesson there. Same pathway, different tissues, critical interaction. What about leg pain from blocked arteries? Peripheral artery disease, does vasodilation help there?
Peripheral artery disease, PAD, that's atherosclerosis blocking arteries in the legs, causing muscle ischemia and pain during exercise claudication. Treatment involves risk factor control, cholesterol, BP, smoking, diabetes, exercise therapy, antiplatelet drugs to prevent clots, and major events like heart attack or stroke.
But do vasodilators help the leg pain, the claudication?
Here's where it gets counterintuitive again. Conventional vasodilators are generally not beneficial for claudication.
Why not? Seems like increasing blood flow should help.
It's that phenomenon of steel again. In the legs with PAD, the blood vessels in the ischemic muscle areas downstream from the blockage are often already maximally dilated trying to get blood. If you give a drug that dilates all the vessels non-selectively, it mostly just widens vessels in the well-perfused areas.
And shunts blood away from where it's needed most.
Exactly. It can literally steal blood flow from the ischemic zones, potentially making the claudication worse. Dipyridinol is a classic example that can do this.
But there are drugs that help PAD symptoms.
Yes, but they work differently. Cilostazol is approved. It's a PDE3 inhibitor, different from the PDE5 inhibitors. It has some vasodilating effects, but also antiplatelet actions, and it specifically improves exercise tolerance in PA. Another drug, naftaterfural, is used in the UK. But the broad vasodilators, generally no help for the leg pain itself.
Okay, that's a really important nuance. So looking beyond these, what's new on the horizon? What are the newer frontiers in antianginal treatment?
There are several exciting newer antianginal drugs. Ranolazine is approved in the US. It has a unique mechanism. It reduces a specific late sodium current in heart cells.
Late sodium.
Yeah, it's a sodium influx that happens late during the cardiac action potential and can contribute to calcium overload in ischemic conditions. By reducing this late sodium current, ranolazine indirectly helps reduce intracellular calcium, which lowers diastolic tension, contractility, and heart work. It's effective for stable angina.
Any issues with it?
It can prolong the QT interval on the EKG, which always raises eyebrows, but interestingly, it hasn't been associated with the dangerous arrhythmia torsades de pointe. It can interact with the metabolism of some other drugs, though.
Okay. What else is new?
Then we have the metabolic modulators, the PFOX inhibitors we touched on earlier. Trimetazidine inhibits fatty acid oxidation, pushing the heart towards using glucose more oxygen efficient. It's shown efficacy in stable angina, used widely in Europe, but not approved in the US. Perhexalane does something similar, but had toxicity issues related to genetic variations in metabolism, so it's not used now.
Shifting the fuel source.
Exactly. Then there are bradycardic drugs like ivabradine. This one is very selective. It blocks a specific channel called IF, the funny current, only in the heart's pacemaker, the SA node.
So it just slows the heart rate, nothing else.
Pretty much its main effect. It inhibits that hyperpolarization-activated sodium channel, reduces heart rate, reduces anginal attacks with efficacy similar to CCBs or beta blockers. A big advantage is it doesn't affect smooth muscle much, so fewer side effects like constipation or bronchospasm. It is approved in the US, but primarily for heart failure. Use for angina is off-label here.
Interesting. Anything else further out?
There's research into rhokinase, ROCK, inhibitors like Vasodilators. Rhokinase is an enzyme involved in smooth muscle contraction, so inhibiting it could reduce coronary vasospasm. Still investigational for angina in the US, Europe, and surprisingly, allopurinol.
The gout drug.
The gout drug. High-dose allopurinol has shown some promising studies for prolonging exercise time in angina, possibly by improving endothelial function, how the blood vessel's lining works to cause dilation, but again, not currently approved for angina.
So what does this all mean for the future? It seems like we're moving towards much more targeted, precise therapies. beyond just widening pipes, but really optimizing heart energy use, targeting specific channels, maybe even addressing inflammation.
Absolutely. It's about understanding the pathophysiology at a deeper level and finding more refined ways to intervene. It's a continuous push for therapies that are not only effective, but also safer and tailored to the individual.
Well, today we've really gone on quite a journey. Started with that common symptom, chest pain, and dove deep into the cellular dance of vasodilation. We've dissected how familiar drugs like nitroglycerin and calcium channel blockers work right down at the molecular level, why their formulations matter, how they're strategically combined, and even uncovered some surprising other uses and those critical interactions. Plus, a glimpse at the new frontiers.
It really does highlight just how interconnected everything is in the body, doesn't it? And the huge impact of tweaking even these tiny cellular pathways. We started with a patient case, and by exploring the detailed pharmacology, we've hopefully built a real mastery of the principles behind those clinical choices.
Yeah, it's definitely more than just memorizing drug names.
Oh, much more. It's about appreciating that complex interplay between physiology and pharmacology, the how and the why.
Which really makes you wonder, as we keep uncovering these incredibly precise biological mechanisms, these specific channels and enzymes, what other conditions, things that seem totally unrelated today, might we be able to treat down the line just by tweaking one of these tiny levers? It feels like it could unlock a whole new realm of therapeutic possibilities we can't even quite imagine yet.